Hello, my name's Helen Elliott-Mainwaring, Helen M. I'm here to tell you a tiny portion of my PhD, and this is entitled The Unintended Consequences of Digitalisation Changing Workplace Culture. I have been incredibly lucky to have been sponsored by the Healthcare Improvement Studies Institute for the last 4 years. I've been supervised by Dr. Nicola McIntosh from Social Science Applied to Healthcare and Improvement Research, and Dr. Nicola Bateman from the Business School in the University of Leicester, and Dr. Nicola Bateman has a special interest in visual management tools. So this is interdisciplinary research. It's been largely quite tricky to navigate. So a quick page on me. I've worked in healthcare for 35 years. I was a care assistant and a ward clerk. I did my nurse training with Project 2000 in the early 1990s, and I was in the first cohort of nurses who were allowed to train to be midwives in Oxford Brookes in 2000. I'm showing you a bunch of my qualifications, not to show off, but to show you what lifelong learning really looks like. So up here you can see two tiny tots. This photograph was taken almost 20 years ago. So my eldest daughter is at university at a time when I'm finishing my PhD, which is a very strange situation to be in. And this tiny tot is actually doing her A-levels. So yeah, so I'm a mum who's always worked alongside studying, and my children say, Mum, all we've ever known is you working as a midwife and studying, which I think is really important to set a standard for yeah, courageous young people. And then I've given you a couple of photos from home life, and that's really to do with sustainability and biodiversity. These are really key features in our lives. Actually this research is about human well-being and what it's like to thrive in a modern world. So I've focused in on visual management tools, and I've used these as tools to open up conversations with staff who work within maternity services. Visual management tools can be incredibly basic. They could be coloured lines on the floor. So if the coloured line for accident and emergency suddenly stopped in the cafe, Costa would be in chaos. I've focused in on early warning scores, which work on a track and trigger basis. We've had them for about 20 years. There's a big piece of work ongoing at the moment with Professor Tony Kelly in terms of improving these and creating Muse 2. We have S-bar tools, which are there to really help us to articulate transferring information across hierarchies. And we have sepsis tools, which were created by the UK Sepsis Trust in 2007. And since their conception, we've had a 50% reduction in mortality in relation to sepsis. And within my PhD, funding, there was an agreement that I would look at the tension between paper-based analog tools and digital tools, and so that has been the basis of this PhD. I conducted an enormous systematic literature review in the first year of my research, covering 3,500 documents. I settled on 49 of them, and this was across the global stage, and I discovered that Asian research is really good at researching the transitions to digitalisation, whereas in the UK, really not so much, which is lovely for me because this really provides a niche justification for my research. I've used a couple of frameworks, and one of them was from Stephen Shorak, and it's the varieties of human work. So I've looked at 17 workers' imagined policies and guidelines, 20 national reports, and I interviewed 55 members of staff. Predominantly this particular presentation will just focus in on some of the findings from interviewing staff, because in 10 minutes I really can't tell you about an 80,000 word thesis. But where these varieties of human work coincide, that's where we see safety, and where there is dissonance, that opens up a space for us to talk about quality improvement. This is a map of my participants from across England. I asked everyone during consent whether they would be prepared to give me the first half of their postcodes. Everybody agreed, they didn't have to. You can see a cluster in the Midlands, which makes sense because that's where I'm based. I wanted my research to be broadly representational of the multidisciplinary team, and this I achieved. I've also used the Systems Engineering Initiative for Patient Safety. This is SIPES, created by Holden and Carrion. This has been adopted by NHS England and by HSIB, and this forms part of PSERF, which has been with early adopters for the last couple of years and is going live later this year across England. So this was a really important framework for me to use in terms of focusing in on tools and technology and understanding the complicated systems that we actually work within. And using SIPES and PSERF should lead us to a better understanding of not blaming staff when things go on, but understanding the bigger picture of what staff are actually working with. So when we look at maternity services in England applying SIPES, we've got systems, processes and outcomes, which comes from Deming, the godfather of engineering. And Don Obedian said a system is perfectly designed to get the results that it gets. So the results that we have, our outcomes, are 62% litigation payments, which was 8.2 billion for the year 2021. 57% of midwives responding to an RCM survey, so they were planning on leaving in 2021, and we are in the eye of the storm at the moment. And we have a 30% attrition rate from specialty trainee doctors. So let's have a look at what's really going on. We cannot change the human condition, but we can change the conditions under which humans work. So what worked well? Because some stuff really did work well. These were the outliers, to be fair. So Senior 10, the other thing that's super handy is if you're escalating to a doctor, they can obviously access the patient's records from wherever they happen to be. This is why it's really important to get different versions of reality, because Dr. 2 said it's very quickly you can see everyone on your department, but the downside is you do need to have access to a device to view it. Multiple automated alerts was something that came up from a particular platform, and I'm agnostic, there are lots of different platforms being used, but Trust that we're using this particular platform said that multiple automated alerts was junk mail. Little things like that tend to take a back seat. It's a novelty that's worn off, and it's a bit like overload. So what we see is alert fatigue, decision-making fatigue, we see workarounds, and we see a normalization of deviance. And I had this with doctors telling me that when they were signing in on this particular digital system, they might perhaps just be wanting to write a prescription. So then they were batting off and deleting the automated alerts that came through because they didn't have time to deal with them. They weren't necessarily their patients. So the system is not designed for the way in which the staff are working. So this is something that we really need to know about, and CYPS is a great way for identifying these problems. And so we need to actually create a system that has automated alerts that aren't inundating staff to the point at which they just can't deal with those problems. So you might have a system or a tool that really efficiently solves one problem, i.e. escalation, but it just moves everything and perhaps even overwhelms it, more OBS on less sick people. And this is what we are seeing at the moment. So the tool links us all, but the tool alone is not going to fix the problems. And this was a beautiful quote from S4, because you've not given me the resources, you have not given me the staff to be able to adequately manage this. So the tool will only be useful if I have the right level of staff with me, and that's ultimately the reality of it. You're only as skilled as your tools as your team is. It's about everything. The tool links us all, but the tool alone is not going to fix these problems. I looked at the sticker phenomenon, which seems to be something that's tied in with digital change requests. So on these electronic pathways, where there are local and national reports and investigations and staff have to create action plans, they sometimes need to change those digital platforms, and there's a time delay. So for example, on K2 it would take 18 months to bring in these changes. Badgernet was 2 years, Nerve Centre was quicker. But the problem is that managers are then creating a workaround to this, which is stickers as a solution to plaster over the problem, because they still need to gather their governance and auditable data. So M10 explained that it really depends on how your trust contracts and licenses and agreements are planned out, and they're not necessarily specific to maternity services. And so this does become a problem. I created a cognitive task analysis of sticker use. It's very, very easy to create stickers, but from a staff point of view, where will they be stored? Who will maintain ordering and printing the stickers, and who will replenish them? And will the stickers actually be sticky? So we're looking at staff dealing with emergencies. What if I can't find them when I'm in an emergency, on top of actually dealing with the emergency? And M2 said, for an emergency, I remember being pulled up and had my wrist slapped for not using an S-bar sticker. I couldn't find the S-bar sticker. So this is a problem with our system, because M2 actually left clinical midwifery. So S7, I could escalate to the moon and back. I could use as many escalation tools as you want to throw at me, or as many stickers but we're supposed to be going paper free, so here's another sticker. And then some of those aren't even sticky, so you have non-sticky stickers. And this is a problem in terms of standardization and the workload that we're actually putting upon our staff that are already working short-staffed in very, very busy systems. So I wanted to finish on a high, and this is the quick response codes, which it was a joy to watch unfold on Twitter. So I was interviewing staff from across England who didn't necessarily know each other, and the staff that were working in trust that were using QR codes were saying it's an absolute game changer. And in terms of what good looks like and understanding human factors and technology, this is fantastic, because it means that for locum staff, for agency midwives, who aren't necessarily familiar with the nuances of policies and guidelines in a particular trust, they can click on the QR code and they can take those policies into the room with them to navigate, which is very, very different to blowing the dust off paper-based copies or trying to find the right words on the clinical internet. So I wanted to finish on a high and just share that one with you, because that's a really good news story. So in our messy reality, with workers reported and workers disclosed, we've got an understanding of human factors and problem sensing. And where we have workers imagined joining in, we have safety. And where workers imagined and workers reported join, that's comfort seeking, that's tick boxing. And that's a real problem, because we need to understand the soft intelligence of what's really going on within healthcare. So there are lots of little quotes here. I haven't got time to read them all out, but there's one in particular that I want to share with you. And it's from Dr. 2. It's always a bit strange when you're managing an emergency in a new place, because you haven't yet made those relationships. And that's the bottom line of this research. It's about how we make human well-being and make those relationships, because it's a relational experience that we work within in healthcare. So I give you some references. Thank you for your time. Any questions?